right. This so and also my dedication to my gurus, especially Amitabh Vikrama sir, who hopefully is listening to me, and he knows who he is, and that's my homage to him. So this is basically my experience over the last 2 and change years or 3 and change years in the UK. And my topic for today is how, as interventional radiologists, we deal with patients who have undergone trauma. So it is unfortunately one of the leading causes of death in young individuals. And obviously uncontrolled blood loss is the most common cause post-trauma. We've got a golden window of opportunity. And what I mean by that is we hit early and hit hard to really help these patients that are on the edge almost. And as IRs, we have become an integral part of the trauma response, both in terms of reading the CT, who are which our diagnostics colleagues can do as well, but also managing the patient after the CT has been read and we figure out a treatment strategy. Now, the one thing that has come out of the Afghan war in 2011 is the fact that there was a lot of trauma, obviously, for soldiers, right? And and we had to have a way of imaging these soldiers quickly, right? And the BASTION protocol was developed to save not only contrast boluses and quantity, but also to image quickly and to obtain as much information from one scan as possible. So this is a standard. I hope you can see the arrow. This is a standard single bolus technique for a CT where you give your contrast at a certain dose and flow rate, and then you image it around 30 seconds for an arterial and image it 70 seconds for a venous. So you have 3 imaging sets. If you've done a plane, you've got a plane, then you've got your arterial and your venous sets. Now the BASTION protocol will help where you split the boluses. So you give your contrast, you split the bolus approximately in half, give your first dose at a venous rate, your second dose about 30 seconds before you acquire, which is at an arterial dose, so slightly higher rate, and then you image once. The advantage is an image like that, where you get not only an arterial enhancement, you also get a simultaneous venous opacification, right? Obviously, this will not be useful for identifying a venous lesion, for looking at washout, etc. But if you want to figure out arterial injury, and if you want to figure out extravasation, extravascular blood, which is what our idea is in trauma imaging, especially vascular trauma imaging, this really does the job. And this is what we follow at UHCW at Coventry. So most organizations in the UK do follow this as a principal mechanism of imaging a patient with trauma. Now, how do I read a CT? There's 2 surveys to the scan. The first survey is called a primary survey. And the primary survey is for, essentially the brain, the spine for trauma, the heart for pericardial effusion and fluid elsewhere in the body, right? That's your primary survey. The IR evaluation of the CT comes after the primary survey, where we're looking for foci of bleeding and looking for foci where we can intervene, right? The first thing that I look at are the 3 solid organs, which are most commonly liable for injury and trauma, and also the easiest to manage in terms of, well, I'll come on to the strategies later, but these are the 3 things: the liver, the kidney, and the spleen, all right? Then you look at vessels near areas that are commonly fractured or damaged, like the pelvis, so vessels near the pelvis, in and around the pelvis. Then you look at areas of shear injury, where essentially areas which are fixed and move tangentially in an opposite direction when there's deceleration or acceleration trauma, commonly the aortic isthmus, and also in the rectus sheath, the inferior epigastric artery. Then you obviously look at the lower limbs. Now, lower limbs transaction injuries should already be sort of given to you by the paramedics that bring the patient in. It'll be an obvious injury, sort of, swelling or a fracture. So it'll be obvious where you need to look for. But these things, the paramedics might not have an idea, the 3 things that I already said. And also an additional clue in the scan would be the adrenals and the IVC. Obviously, if you have streak adrenals and a flattened IVC, the patient is hypovolemic. Obviously, the team would know that, but there are some patients that are fluid responders that might not look like this, and they'll be going off a cliff. So it'll be a good thing to know that these patients need to be rushed into treatment, right? Now, so this is the next bit to really get into the technicalities of looking at a CT. I've already told you the places that I look at. Now, how do I actually assess the bleeding, right? The first thing that I look at is for delayed imaging, right? Now, in a Bastion protocol, obviously, the imaging is already delayed. But suppose we do have something like this, all right, where the image on the left, this is a trauma, and you can see there is no real organ in the splenic region. It looks like a big mass of hematoma with lots of fluid around the liver as well, right? It looks like hyperaccumulating fluid. We can assume that this is blood. However, the real use is when you take the next phase. Now, the next phase, you can see pooling of blood, right? And that is active contrast extravasation around the liver even in a really bad splenic trauma. We will come to this case later on because I'll let you know what we actually did to manage this patient. So that's the first thing that I would look at, right? Pooling of contrast. And pooling of contrast generally means that there is active hemorrhage, right? Also look at the maximum intensity projections. Now, maximum intensity projections will tell you as an IR how do I get to the point of bleed. Now, this is not a case of trauma, but this is a case where MIP really helped me. As you can see, there is a bleeding in the splenic flexure here. Excuse me. And the IMA gives off a really loopy branch to the splenic flexure, right? And I was able to trace out this entire branch and really plan my intervention ahead, right? You can use various catheters. You can even sort of choose and understand at what stage you need to shift your microcatheter, etc., based on an MIP image, and that really helps to plan the intervention. The third thing that I would always try to differentiate is this bleed an intraperitoneal bleed or a retroperitoneal bleed? And the reason is because retroperitoneal bleeds are more forgiving in the sense that it's more of a closed space. All right, the hematoma starts to dampen out the bleed earlier than an intraperitoneal. The space is so large, it keeps bleeding before the patient falls off, right? So they present in more hypovolemia than retroperitoneal. In essence, you've got more time with the retroperitoneal bleed. Both are sort of important, but you've got more time with the retroperitoneal, right? And the next thing that I always plan are the access vessel approaches. Now, for most of these trauma cases, we do femoral access, but there are a lot of centers in the UK and in India that we do radial access for. Now, obviously, to understand which access is easier, I mean, I prefer the femoral access just because we've got closure devices as well. And we've done quite a few of these cases on the femoral access, so I prefer it that way. The way I look at it is, do I have a direct path of access to the vessel that I need to cannulate? Most of the time in traumas, they are internal iliacs or one of the epigastric vessels. Excuse me. And you look at tortuosity because in essence, when you get a wire passed into an artery and all the vessels proximally are tortuous, the one way of making sure that your access is stable is by increasing levels of support, right? So you use a long sheath, then you use a longer catheter, then you use a microcatheter. So more axial systems that are increased, the more support there is. So the tortuosity is important there. And you always have to rule out variance as well. And you need to understand which vessel is finally supplying your target. Because in essence, imagine you shoot a torpedo at the wrong target, it'll still bleed and you'll have a false sense of security, and that doesn't work for trauma patients. So this is a case example. We had a 76-year-old male stab himself right down the middle there. Now, this was the Bastion protocol. Now, this is a situation where the Bastion protocol did not help us in the sense that the patient was hemodynamically stable, right? Now, the next question is, why are you trying to embolize a patient who is hemodynamically stable, right? Now, the problem with this particular scan is it does look like a pseudoaneurysm. Now, as an IR, you will not leave a pseudoaneurysm no matter the size, right? You can keep them under watch, but in eventuality, you have to sort of embolize it and take out a pseudoaneurysm because as described, a pseudoaneurysm does not have a proper wall. So it can rupture and hemorrhage, especially something that's on the subcapsular aspect, which means that the only area it's going to hemorrhage, sort of blow out into is the peritoneum, and that can cause torrential bleeding, right? This can also be a venous lake, right? This could be a portal vein that's been slashed peripherally, and this could be a potential venous lake. So how did I differentiate between those two? In this case, we actually got a repeat CT because we wanted to figure out, is this pooling increasing? All right. And is this a pseudoaneurysm that we need to embolize versus if it's a venous lake, we can hold tight and not embolize and not intervene. This is the plain scan. Next is the arterial. As you can see, a small sort of remnant and you can see an abnormal blush there, but that abnormal blush is increasing. So that told us that this is definitely an arterial phase and a fairly fast flowing and a fast increasing blush, which is definitely a pseudoaneurysm that is filling. All right. What do we do for this patient? We embolized, so we distally cannulated the feeding vessel, and when we did, it was almost, they were extremely spasm. I mean, there was significant vasospasm on the way and also to the lesion. But we did eventually demonstrate it in the left lobe. There's the pseudoaneurysm there. Since we could not reach all the way, in essence, the way to treat these is to either reach the pseudoaneurysm and fill it up with coils or fill it up with microspheres. So I'll come to this, but embospheres are small balls of, well, in essence, plastic that we push into the body, and they end up settling inside the voluminous space, fill it up, and then we also coil embolize distally to make sure that there's no forward perfusion into that space. And that is a way to manage these. Now, this is the final run as well. Patient was absolutely fine post-trauma and settled well as well, did not have any bleeds following that. Now, this is a quick slide to explain what are the different stages of trauma in a vascular system. Obviously, the one that can easily be understood is contrast extravasation or rupture. That's grade 4, right? The grade 3 is where it's almost rupturing. So in essence, you lose all the vein walls, and what's been held upon is either the adventitia or some sort of fibrous tissue just holding it together. It's a temporary fix by the body, and it will let go over time, right? The grade 2 is when it bleeds into the vessel wall, but it's contained by the vessel wall. At least some of the muscularis is still containing this, and this is within the wall. So it's called an intramural hematoma. And the first and the smallest sort of degree of tear, of injury is an intimal tear. Now, for an IR, to be honest, one of the most dreaded is also a dissection, because a dissection sort of stops you from getting distally. So for us, even though the grade of injury in terms of bleeding is small, it's still a fairly significant injury if there is a dissection, right? Now, let's say it does rupture. Sometimes it ruptures into the neighboring vessel, and it's contained by the neighboring vessel and forms a fistula between the artery and the vein. In that case, you can have an AV fistula. Now, I will show you DSAs of all of these over the following cases, and hopefully you'll be able to understand that better. Now, this is a case of vessel transaction, just to understand what it looks like. So this is a digital subtraction angiogram. In essence, it's an angiogram, continuous frame rate, about 2 frames a second. And we've taken off the bones from it by using a mask and subtracting it on it, right? This is an internal iliac angiogram for a patient post-trauma. And as you can see, as we move on, the flow to the superior, the SGA, the gluteal arteries are fine, except there are 2 foci where there is contrast holdup. And the vessel seems to show almost an inverted flame-like appearance. It looks like a flame. In essence, that is because there is dissection and cut off of the vessel. Now, as of now, this vessel is not bleeding, but the moment there is further injury or further hyperpressurization of this chamber, it can give way, and there's potentially going to be torrential bleeding from this. So a vessel like this, both of these points need to be taken out with coils or whatever embolization agent you use. Now, we did start off in a very humble way initially. This is Charles' daughter, the father of IR, and in 1972, the first embolization procedure was reported, and they used autologous blood to embolize a bleeding GA, gastrocleploic artery. Now, autologous blood, in essence, is you put in an IV line, you take blood out, you leave it in a syringe, it settles, and then you sort of separate out the plasma from the clot, and then you use the clot as a embolization material. Now, people still use this. In fact, we use it in our practice for liver and lung biopsies. So the tract post lung biopsy, we actually use autologous blood to block off the tract to prevent pneumothorax, right? But what can we do now for bleeding vessels? We're obviously much more advanced these days, which is why we push on the vessel. Obviously not. What I'm talking about is pushing on it from inside, right? So essentially, if we give pressure from within the artery using a balloon, that's something that IRs can do. We can also reconstruct the entire vessel using this structure, which is a stent graft. So we can basically reconstruct the entire vessel, block off all the holes that the vessel has, and create an entire new conduit for the blood to flow. But more common than that is what we use embolization agent to occlude the bleeding vessel. Now, these are coils, which are basically metal strings that we put inside vessels that occlude it. These are called plugs, which are another iteration of coils, except they are detachable. And there are also liquids that can be used as embolization agents. This is onyx, which is an expensive embolization agent, which in essence acts like lava. There's also glue, which is similar. And this is the embospheres, which you already saw in the other case, which are small microparticles that agglutinate together and travel very distally to reach the distal bed of lesions to occlude them. And this is gel foam. Gel foam is, in essence, a temporary embolization agent that is somewhere in between solids and liquids. It does behave like a liquid though, but it can be used in iliac trauma, as I will come to later. Now, let's go to some solid organ injuries. I'm not going to explain the whole thing, but in essence, a grade 4 and 5 are significant injuries and they have to be dealt with. Most of the time, it's not going to be conservative management for those two. Grade 3 potential for conservation is there, and non-operative management. Grade 1 and 2 most of the time is non-operative management, right? So if you have a vascular disruption or a significant parenchymal injury, most of the time this is what it looks like. So this is a 50-year-old male, excuse me, post road traffic accident. He's got a significant arterial blush there. A lot of the liver parenchyma is not seen, and there's a big hematoma around the liver as well and the spleen. So this shows that there is significant extravasation. We've graded this as a grade 4 injury. On the angiogram, we see there's multiple areas of pseudoaneurysms from one of the branches of the right hepatic artery. Excuse me. And you can see significant vasospasm of the vessels distally. That shows that the patient has a significant adrenergic response, and the adrenergic response is making the vessels spasm, right? It's a response of the body to blood loss. Now, we've taken the vessel out. This patient did really well. And in essence, what we've done here is taken it out from the proximal bit all the way across and made sure that even the distal bit is covered. Now, this is a method of embolization which we call as backdoor and front door. A lot of times people do not do backdoor for livers, but in our experience, we figured out that backdoor embolization is paramount for livers as well, because there's a collateral circulation that can come from the other end. Now, this is another case explaining another important bit. 30-year-old male came with a stab. Now, obviously, you can see there is active extravasation on the CT. This patient went into surgery because he was extremely unstable. So all of these sort of radio opacities that have been subtracted are gauze, surgical gauze swabs that have been packed. And the patient went back and started, being unstable again, stabilized for some time. We went in, did an angiogram. As you can see, there are no major areas of bleed here. It's only vasospasm. But what we did was we went selectively into the point where we thought it could be injected, and then behold, there is a clear pseudoaneurysm, which we then took out. Now, obviously, this patient had multiple pseudoaneurysms. We had to go into multiple branches and take out a lot of blood supply. Now, you could ask, this patient has, obviously, you've taken out a lot of the liver. What happens to the liver now? Because there's a lot of liver already missing from the injury. You've taken out, embolized a lot of the liver. But what you must understand is hepatic parenchyma's predominant blood supply is the portal vein, not the hepatic artery. Right now, hepatic artery is causing bleeding. Portal vein is supplying whatever remnant parenchyma. And even if the patient loses 3 to 4 segments, still the liver can regenerate, right? Because hepatectomy involves most of the time 4 to 5 segments. So these livers do regenerate, especially for a 30-year-old gentleman. Right. Now let's move on to splenic injuries, which is the most common organ to be injured. There are 2 concepts of splenic embolizations that are important to understand. The first is proximal embolization, which means you embolize the splenic artery at that point, right? Now, if you embolize it proximally before the hilar bifurcation of the splenic artery, what happens is the spleen is still supplied by collaterals. Now, in our experience, the patients that have presented to us have been in so much hypovolemia that even if you do a proximal embolization, the spleen does not receive blood at all, and we do get complete ischemia. But the principle is that if you embolize proximally, the collaterals sort of redistribute and fill up the splenic parenchyma with blood, and you don't lose spleen, you only depressurize it so it stops bleeding. right? The importance is that if you don't lose spleen, you don't need, protection against opportunistic post-splenectomy infections. You don't need, vaccinations. And also it's an immune response that the spleen generates. It's an important immune response generator. So we try to preserve spleen as much as possible. But the way we do that is by trying to selectively embolize in as many cases as possible. All right. Again, injuries are 4 and 5, very similar to this to the liver. When there's massive disruption, you have to treat. Otherwise, you can go selective. Now, this was an interesting patient. He was a 73-year-old gentleman doing some DIY activity. He was on Apixaban, which is a 10A inhibitor, as you know, and he had an EVAR as well done for him for an aortic aneurysm. Now, what happened there was, this was the case that we discussed initially, where the delayed imaging showed that there was an active extravasation around the spleen. And this was a secondary hemorrhage because this patient presented before, didn't do anything from the casualty, didn't even get an image because he was stable, went back home, had a secondary bleed. On the angiogram, we didn't even know where this thing is coming out of. The entire spleen seemed to be extravasating. It was a diffuse sort of ooze from the spleen. In this case, there is no selective embolization. We took the entire artery out, and this patient did really well in terms of hemodynamics. Then he started having an abscess because in essence, he lost the entire spleen, didn't he? And that abscess was drained, and we've basically done a interventional splenectomy for this patient, a minimally invasive splenectomy. He's not got a spleen now. Obviously, this patient needs to be put on post-splenectomy, antibiotics and stuff. Now, this is if the patient is fortunate and you are having a good day, these are kind of cases that come where you've got a distal sort of lesion where you can really preserve most of the spleen and go quickly and distally and embolize these patients. And we've taken a microcatheter all the way to the distal bit, embolized them, and you can see the rest of the remnant spleen is there. We've taken about maybe about 25% of the spleen, the rest is there, and this patient did really well. This is a fairly rare situation where there was a 17-year-old man in an RTA. It looked fairly well preserved, the spleen, except for a little bit of diffuse, hemorrhage. The rest of the spleen did look good. But when we did the angiogram, we saw multiple foci of microhemorrhages within the spleen, right? That basically tells me that the parenchyma, and there was no parenchymal blush. This is where it ended. There was no parenchymal blush. As you can see, this is a delayed run. The problem with these cases is that the spleen is basically gone. Now it's just hemorrhaging into itself and outside in time. So the only answer here is to take out the entire supply to the spleen. So we took out the splenic artery with coils. Right? Now, the third solid organ, renal trauma, again, the same thing, 4 and 5 massive injuries need to be dealt with surgically or IR. And the proximal 3 grades you can, conservatively manage. This was a patient that had a stab, 20-year-old male. Again, when we did our first angiogram, we did not see any, blush at all. We didn't see an abnormal vessel in the space. Parenchymogram looked okay. And then we went selectively because that's the next step. You go selectively and pressurize like we did in the other liver case. But selectively also, there was no major injury. Then we waited for the parenchymogram, and you can see there is a wedge-shaped area where the knife has gone in that was not enhancing and opacifying, right? And obviously, based on this CT, this patient was definitely bleeding. This is an adrenergic response in vasospasm. So we definitely need to take out the feeding branch. So we went in selectively into the space there and took out that branch distally. And this patient did really well, stopped bleeding and was hemodynamically stable. We got a CT as well to show how much of the liver parenchyma was taken out with a wedge, the kidney, the renal parenchyma, with a wedge from the, distal to the coil embolus. Now, pelvic trauma is the next series that you have to deal with. It can be multifactorial in the sense that you can have osseous injury, unfortunately, and that's the thing that causes regional vasculature to be injured. And embolization is preferred over surgery, even in hemodynamically unstable patients. This is the caveat here, where for pelvic trauma, it's so difficult for surgeons to go in and actually get control of these things because of the complex anatomy there. For us, we basically got puncture and vessels, fairly easy, and we've only got the internal leg to target. So for us, it's relatively simpler to reach than surgeons. So therefore, you need to fix the entire pelvis in place just before we get in, after we cannulate the artery, and then remove the binder and then do a gram. You will be able to demonstrate the bleed, and then you take it out with some sort of management. Now, this is the place where we can use gel foam. Up to now, I've spoken about particles, I've spoken about coils, also, liquid embolics like glue, but gel foam is useful in pelvic vasculature. Just because the pelvic vasculature has so many collaterals, it's useful to hit it with gel foams if you're not sure as to where it's bleeding from, or if you've got multiple foci of bleeds and you don't want to spend that much money or that much time to embolize in case you don't have enough to resuscitate this patient. This is an example. Unfortunately, we didn't have a case. I mean, at least I have not done a case where I've used gel foam for the pelvis, but this is a case that I got off the internet in in a reputed publication, where essentially this is bleeding out of the internal iliac artery on the left. And as you can see, that's significant ooze, and it's an active hemorrhage. So what they've done here is short it with gel foam and then backdoor embolize with coils, right? So in essence, you've used a slurry to take out the branches distally. It doesn't matter how distal it goes, and then proximally embolize with a coil. Now, the reason you take out the bed is in case the bleeding distal to that, because you can't see the bed beyond the extravasation here. This is a case that came to my clinic, or to one of my calls, where this lady unfortunately had a trauma, had multiple fractures all over her pelvis. Both her iliac bones, I mean, pubic bones are fractured, as you can see, they're comminuted as well. There was an active hemorrhage in the pelvis. There she was unstable. We've done a run and we figured out that there's multiple foci of hemorrhage. This was a deep paravesical branch that we went down, pushed a little bit of some particles in, and then we coiled off the branch as well. This as well, there was some abnormal foci here. There was an active extravasation there, so we took out the branch completely. Again, this patient did well, and that again, these were focal coil embolizations in pelvic trauma. Now we come to the limbs. Now, in limbs, the difference here is, up to now we've been talking about taking out the vessel, right? All hematomas and all pelvic traumas in this case have been about taking out the vessel by embolizing. Now, if you need, obviously you cannot embolize off a lower limb vessel because you need perfusion to the leg to maintain to keep the limb of the patient. So therefore, what you try to do is reconstruct the vessel. Like I told you, there are stent grafts that we can use to reconstruct. Now, this is an example of a 36-year-old male that had a stab injury to the thigh. This patient had a communication between the artery and the vein. So as you can see, there's an early filling vein. So we've got a wire across that and put a stent graft and reconstructed his entire vessel. So that's the common femoral artery, the superficial femoral artery, and the profunda femoris artery. We've basically put a graft straight across, and you can see this is a 6-month follow-up. Phenomenal. This patient is still on our care, I think about 2 years post-intervention, doing really well. This is an interesting case. 72-year-old male came in with trauma to the clavicle, went home, not an issue, conservatively managed. And he had bruising and blueness and pain in his left hand after the trauma, and about 2 weeks later. Now, we couldn't figure it out. We evaluated him for infective endocarditis. He didn't have any, lesions like that in the heart. Then we figured out, let's get a CT angiogram to understand the artery. And when we did, we saw a pseudoaneurysm in the axillary artery, right? And there was clot that's been forming in the axillary artery and shooting down. And that's the reason why he had a trash hand. And he was actually treated for that reason. So we did a vascular reconstruction of the axillary artery, subclavian axillary artery, using a stent graft where we covered it, as you can see. So that is the abnormality there, a small pseudoaneurysm. And we've covered it up, and this patient is doing really well, has no problems after, and we've maintained hand perfusion. Right. This is also an important thing to consider. A 30-year-old male came into one of my calls post-trauma. Now, this particular patient had a very common injury, which was a seatbelt injury, which is the horizontal bit of the seatbelt at the bottom. Now, he had an active extravasation from the inferior epigastric artery, the right inferior epigastric to be precise, and it was actually going into the intraperitoneum, right? Now, commonly we've understood that the inferior epigastric artery is part of the rectus sheath, right? It lies within the rectus sheath, but there is a demarcation at the lower third of the anterior abdominal wall, which is called the arcuate line, as we all know, and below the arcuate line, The inferior epigastric is not covered posteriorly by the rectus sheath. It's only covered by the transversalis fascia and the parietal peritoneum, which are easy to rip on shear injury, right? If it is injured below the arcuate line, most of these RIGAs bleed into the abdomen, right? And they can have, and they need to be tackled with an embolize. A lot of times they bleed inside the rectus sheath, in which case it should, hold itself. You give a little bit of tranexamic acid and it should settle itself. But in this case, we have to go in and embolize it off, as you can see there. Now, coming to at the end of the lecture, I've already discussed about the shear injury and shear sites that are important, and you need to understand your areas of trauma. Aortic injury are unfortunately the second leading cause of death from blunt trauma. Most of these patients die on the spot. The ones that make it to us, have to be really lucky for us to actually see them from the resus into our theaters and actually put a stent graft across. I'll show you one such case where there was an aortic isthmus injury from I think a deceleration injury from a RTA. You need to look at the three commonest sites, which is the isthmus most common, the root, and the aortic, the aorta passing through the diaphragmatic hiatus. So this is a case where you can see that there is a intramural hematoma, almost a pseudaneurysm at the level of the aortic isthmus post-trauma in this patient. And what we did was a TEVAR, which is a thoracic endovascular aortic repair. Commonly, it's done for the infrarenal abdominal aortic aneurysms, but this particular patient, we had a TEVAR, a stent graft that's deployed through and beautifully sealed it off. This patient is still alive and doing well and in our follow-up. Most of the time, we follow up these patients with a yearly CT for the first 2 years. And then they go on X-ray follow-ups to see how they do later. So to conclude, obviously there is a paradigm shift now towards non-operative management of trauma patients. Now IR fits really well into this particular space where you don't do massive surgeries as part of trauma care. It sort of falls in between surgery and complete conservative management. It's a really good extension to the approach, and also it's minimally invasive. So you don't actually, so for example, if a spleen is bleeding, us going through the vessel and blocking and turning off the tap is unlike them opening it up and taking the spleen out, because it can cause loss of that tamponading hematoma. It's got an excellent success rate, 85 to 100% in experienced and less experienced hands, and it also has a really good value in terms of reducing morbidity and mortality. UK has come out with the NCPOD guidelines, where IR is now a featured specialty in the guidelines, and you cannot have a trauma service in the UK without IR. And also, at the end, the vital bit of information here is you need a multidisciplinary team approach to get best outcomes so that all of us can come together and help our patients. Thank you so much. This is me. I think, yeah, that's the end of my presentation.
Yeah, thank you, Dr. Shankar. That was both the diagnostic, it was very useful for diagnostic radiologists like us, and of course for IR radiologists as well. A couple of questions from my side before we take from the audience. Sure. For trauma involving the whole body, say something like thoracic and abdomen, neck, do you have any specific protocol for a contrast CT? That's one question. Then your lecture has almost made us feel that IR could do majority of the things what surgeons were doing. So what is the scope of surgery versus IR in especially abdominal trauma, solid organs? And any role for mesenteric injuries, any role for IR in mesenteric injuries? The third thing is, do you have a hybrid OR where you have a vascular suite as well as a surgical suite where both of you would work in tandem or in union? And these are my questions.
Yeah, brilliant question, sir. So you've almost answered the first question in terms of is there a role for surgery? So we do have our hybrid system. We don't have one right now in our university, but in most places in the UK, we've got a hybrid sort of setup. We've also got a sort of a makeshift hybrid OR where we go upstairs and do embolize for our surgeons. Now, if the patients are so the way we look at it is we moved into sort of accepting patients more and more who are hemodynamically unstable. the guidelines is that if hemodynamically unstable, they go into surgery. Now, I was talking about patients who have all kinds of graded trauma, high-grade trauma, but who have been stabilized in resus. So if you are not a fluid responder, you have to go in and get a pack done. That's just the way it works. Now, if obviously our anesthetic colleagues who are getting more and more well-versed with dealing with resuscitation and trauma patients, these patients actually they come straight to IR with anesthesia resuscitating, depending on the type of injury it is. So for example, if it's a pelvic injury that who's unstable, it's easier for us to do. Whereas if it's a spleen, sometimes it's easier for surgeons to do. So it depends on the type of patient. Obviously, this has to be a discussion and a lot about logistics, availability of the OR, etc. And who can respond quickest. So a lot of the time, if you go by evidence-based, as of now, the evidence states that if the patient is unstable hemodynamically, they go to OT. That's what the HCPOT guidelines is in the US, in the UK. Now, I'm sorry, sir, I didn't get this. I don't remember the second question.
For a whole body trauma, do you have any specific protocol? You said the BASTION protocol for abdomen, I guess, for head and neck or neck injuries.
Yeah, we run it head to foot. So we give our split bolus. So you do your venous bolus first, arterial bolus, and at 30 seconds after that, you run it head to foot. So just one scan all the way down. And that covers brain, C-spine, back, abdomen, chest, abdo, pelvis, as well as the lower limbs.
We have a couple of questions in the chat box. If you could.
Yeah, sure. So the first question is, can you please show us the case of multipunctate microhemorrhages within the splenic parenchyma and how the patient was managed? So this was a 17-year-old boy. It's a really rare occurrence where there's so much of shear injury within the spleen. There's this bleeding everywhere in the spleen. Now, this patient was managed with this proximal splenic embolization, right? I don't have a CT follow-up for the patient because he shifted into another university because he had some other trauma that was not dealt with by us. So he's moved to London. So I couldn't get a CT follow-up for the patient, but he's doing well in terms of the microhemorrhages. But that was dealt with by proximal splenic embolization because we wanted to diffusely reduce the blood flow to the spleen. How do I tell between a covered and an uncovered stent, and when is it a covered stent, and how do the branches remain open? So you obviously need to identify the branches that you cannot occlude. For example, in the case that I showed, that was an axillary subclavian sort of injury. So you need to make sure the vertebral artery is patent. Yeah, so you cannot cover the vertebral artery. Now, on a picture, you cannot differentiate between a covered and an uncovered stent. The principle is that the covered stent has a PTFE coating on it. So it blocks, so it creates a conduit where the flows do not go outside the artery. And the uncovered stent obviously does not have that coating. So you can have patent vessels on the side of the stent. So you'll have flow through as well as around the stent. Yes. So if you look at the image, you will not be able to differentiate based on the nitinol waving. You will not be able to differentiate between a covered and an uncovered. But this is the principle as to how you use it. Obviously, you need to understand where you're deploying it and which vessels you should not occlude. In this case, subclavian, do not occlude the vertebral artery. The next question is DSA required for all trauma cases? Well, most IR, you have to have a DSA equipment. Reason being, if you've got significant opacity, patients obese, you will not be able to see clearly with fluoroscopy alone. So it's always useful to have DSA. That would be my answer to that. And small cavernous hemangiomas of the spleen. That's a good question. We do not have any previous imaging, but it did not look like the spleen was abnormally enhancing. We're assuming that they're shear injuries. And this patient was really unstable, and that looked like the only place that was bleeding. Everywhere else, except for a face, he was fine. So, which is why we assume that's the cause of bleeding. I think that's, okay, there's one more. How do you evaluate a patient with single kidney or chronic renal disease presenting with grade 3 renal injury, wherein a CT angiography will lead to CIN? That's a really good question. You know what, funnily enough, we had a patient literally 3 days back with this problem where she was already in sort of pre-dialysis, leading into dialysis sort of a thing, didn't have an access. They were worried that we'll push them over to dialysis. But you need to look at risk benefit here. If the risk of the patient dying is more important than the kidney living, I think you need to go with the CT. Most of the time, we go ahead and flush the patient with contrast, because at the end, you can have a remedy to patients that are moving into CIM. To be honest, a lot of times we've given contrast without an issue. CIN's not been an issue. I think that's about it. Yeah.
One more
Good evening, sir. Good
Hi.
evening, sir.
Yes, Dr.
I'm Dr. Sunil. I'm a general surgeon working in a trauma center at Nizam's Institute of Medical Sciences, Hyderabad.
Awesome.
I too had the same question of acute kidney injury with the contrast. But yeah, many of the times we discussed with our nephrologists also. They say the same, what you said. They go ahead with the benefit outweighs the risk. You go ahead, and we are here to do dialysis. We are here to dialyze the patient. So I agree with you, and I appreciate you for your achievements at an young age.
Thank you, sir.
We do get a lot of trauma cases here. The main challenge for us is the cost of the stents. But there is slowly changing the trend with the advent of technology and affordability, and teamwork is required. And lethal triad of trauma, especially hypercoagulable state because of acidosis and hypotension, also do matter in these cases. How do you deal with such scenario?
Oh, it is straight to our anesthesia colleagues, sir.
Right. Agree.
So we've got all the support we need because at the end, we tend to focus on the procedure rather than the holistic care of the patient, because turning the tap off for us is the most important thing. And then obviously there is a lot more that goes into trauma care than just the sort of what I've described today. That's the bit where we get involved as IRs. But you're absolutely right. So in terms of holistic care, acidosis management, getting the kidneys functioning, monitoring urine output, these are things that have to have. I mean, throughout the procedure, our colleagues are working, and we tend to call up something called as a major hemorrhage protocol. So the moment we need a patient in who is hemodynamically unstable, we call an MHP, and then the anesthesia team comes in with, and most of the time these patients are asleep as well.
Yeah, I agree, Dr. Shankar. I have seen that total change in the pattern of the way we manage trauma cases. 20 years back, when I was doing post-graduation, majority of the trauma cases, we used to open the abdomen and to see the findings because imaging was not that developed. And it has shifted to non-operative management with closed monitoring. Now, beyond that closed monitoring, also this intervention radiology is actively participating in the management of the patient. It's a really appreciable change. Thank you. All of you are witnessing the change. Thank you very much.
Thank you, sir.
Thank you, Dr. Rupesh or Shaheen. Anybody, if you want to comment or question. Rupesh?
No questions, sir.
Yeah. Shivu, you have something on neurotrauma or something. Shivu?
Yeah, she posted a question.
Yeah, on neurotrauma or something, it was there.
Trauma interventions. Dr. Shankar, would you like to comment on that?
I'm sorry, ma'am, I have not read the question. It's not my area of expertise, so I generally don't get involved in neurotrauma. I'm sorry about that. And also most of our neurotraumas are managed by neurosurgery rather than neuro-IR, because we've not got a fully established neuro-IR unit in our department. And I'm not very experienced with neuro trauma as such.
There's one more question in the chat box from Dr. Bhaskar. Do you make the holes after measuring the ostia position in the stent? Maybe in the
covered stent.
Covered stent.
I think, yeah, so I mean, I understood the question, but we're not talking about physician modified devices at all here. So for example, I mean, I understand the question. So essentially he's asking, do you sort of create, ostia within the stent to keep these vessels patent? We've never had to do that for a trauma case, honestly, but The one that I did describe is a distal lesion, so it was nowhere near. Rather use a smaller stent graft than to physician modified modular grafts and all that. Especially in a trauma case, I don't think we'll have the time to do all that, because this is literally, go ahead electively. But the one that I did show you was sort of an elective case. Elective cases, you do have time, but if you want to reconstruct a vessel, acute trauma, you want distal perfusion, most of the time it's just stent graft, no modular devices.
Dr. Funny is a radiologist from Nizams.
Madam, good
Yeah,
morning.
please.
Can you hear me, madam? Can you hear me?
Not very clear, Dr. Funny.
I don't know, madam, but now it's okay, madam.
It's fine
Yeah.
now.
Yeah, madam. Good evening, everyone. I am Dr. Fani Chakravarti. I'm from Nizam Institute of Medical Sciences, Hyderabad, actually. Actually, what I have seen in managing trauma, most of the interventional procedures are actually, honestly, are already taken over by clinicians. I mean, it's mainly cardiologists. Like if you see carotid stenting emergency, aortic stenting, like TAVR or something, or renal injuries or peripheral injuries, most times cardiologists are operating on these patients than interventional radiologists. Are there any rules in UK who should perform what cases? Because in India, it's not there actually. Just I want to know the system. This is honestly, I can tell the scenario actually.
Survival.
No, there's governance policies in place in the UK. Anybody can do the procedure, but you need to have governance. That's all.
Yeah. Most of the times, what we are getting is like major abdominal injuries are only mostly they do come to us actually. So whatever cases here shown are very common here in NIMS actually. So, but some of the peripheral things are being taken care by the vascular people or cardiology people actually. So those cases we do get, but slipping out of our hands actually. So secondary thing, what is in emergency? There is an argument in some hospitals in Hyderabad recently. Is serum creatinine compulsory in an emergency situation to get a contrast study?
No, we don't take any creatinine. It's just part of, for example, if it's not come yet, we don't wait for the creatinine.
Okay. That's what we want to know because it's creating some headaches here actually.
I mean, it doesn't matter. Even if it's high, we're still not going to do it. So
Yeah, sure.
it helps nephrologists to plan for, hydration, etc. These patients are always on hydration. They're on blood replacement, etc. So, it doesn't. No, we don't wait for it at all. We wait for the CT and the CT and the.
That's it. Okay, sure. And third thing is like if we include what we are facing like iatrogenic causes also, like as one of the causes of trauma, then the number will be much more than the road traffic accidents or all these things actually.
Yes.
Blood trauma. Iatrogenic are and they do come a lot actually, much more than the blunt traumas actually. It's some post-surgical status or whatever it is, some post-procedural, post-interventional, whatever it is, they do create a lot of bleeding points. That's what we are facing more in day-to-day practice than blunt trauma actually. Thank you, madam. No more questions.
Any role for IR in mesenteric injuries?
Sir, to be honest, I've only come across one or two mesenteric sort of shear lacerations. And we did not have to intervene in either of those cases. Now, the mesenteric root is the most common part that it gets injured, primarily because of shear, number one, and very rarely because of blunt trauma. But you can have mesenteric root lacerations or avulsions. Most of the time, they do settle down. Obviously, if the whole thing is avulsed, then yes, you probably will need some sort of embolization. But I've come across a case that I've personally been involved in, where I've actually gone in and embolized. We managed both conservatively. So I don't have a case, but yes, I have seen them, but we've managed them conservatively. And Coventry is a fairly high trauma unit. We see quite a few traumas, all kinds of injuries, but specific to mesenteric injuries, we haven't seen many.
Yeah.
Thank you, Dr. Shankar. It's comprehensive.
Yes, madam. We did one superior gluteal artery aneurysm, madam, just day before yesterday night, following pelvic trauma. So with the massive hematoma in the entire right lumbar, extending almost to the right upper thigh, actually, massive one. Rarely we see interiliac arteries aneurysms, actually, following trauma. So we got one case, madam, recently.
Right.
I can share in some time later that case actually, but it's a technically simple case, madam. That's what.
As he rightly said, yeah, pelvis is something there, which is, I think, interventional radiologists can overdo research, right? They can,
Yes, ma'am.
that's your territory. Straight away, they can take your help and then.
Yeah, because it's just more
More
difficult.
simpler, right? It is very nice. Thank you very much for sharing your experience, and I would expect your participation maybe a little later also with your other topics which have gone through in your CV. Very nice, interesting topics were there. Maybe I'll
Thank you, ma'am.
your help and then put you sometime later, another quarter or something later, and then be with us. Thank you very much.
No problem.
Thank you, Dr. Shankar.
Thank you.
Thank you.